said, so are you saying that that's the due date, or are you saying that
I will
that's
not
the due
deduct
date
those
with
5
the turn
points.
it in or whatever?
That'll be either turn it in or email by Friday at midnight.
But we don't have to do the turn it in, but it's still due by Friday?
I'm hoping to get turn it in up and running.
Okay.
That's why I'm giving the extra days.
Wait.
Oh, no. Okay,
What?
look, you need to turn it in Friday, 11:59.
So is that the most important, but does it have to already be checked in by turn it in?
Well, if I can get turn it in set up today, I'll send out the instructions, and then we'll have plenty of time to get it done, right? But if I can't get it figured out, I'm gonna spend the next 2 days in clinical, and I'll just have you guys do the email.
I'm good with that.
You're good with
So there's
that?
not a place on Blackboard for us to submit it?
Correct.
Okay.
Not at this time.
All right. Moving on.
Here we go.
So let's see, nursing care of respiratory conditions are pretty obvious. Most of these things are supportive care, right? Abdominal wall defects. Why are there abdominal wall defects? Why is there gastroschisis and phalloceal? Why do we have problems right here and right here?
That's where everything comes.
Because we come together when we invaginate, right? When during embryonic development, the embryo elongates and then invaginates and comes together and go in the middle. And that's why we have these midline defects that run down along our palates and our abdominal wall. Because it's an error of invagination. So gastroschisis is when the stomach intestines herniate through the abdominal wall. They literally are outside the abdomen. Okay, and then phalloceal is when they protrude into the umbilical, just into the umbilicus. They don't leave the body; they just kind of protrude out. And the lowest level phalloceal is an umbilical hernia, which are incredibly common. Even I was born with umbilical hernia, where newborns have just a little herniation right at their belly button for like a year or two, and then it goes away. In my day, they used to repair it, so I have a little smiley face scar on my belly button. But now they just know that it'll go away before they turn 5. Just leave them alone. But so gastroschisis is the stomach, the abdominal contents are outside the cavity, and phalloceal, they protrude into the umbilical cord. Okay, both of them are very dangerous, and the last baby I had with phalloceal died in the first 6 months of life. Depends on how much goes into the umbilical cord. Okay, if you got just a little, like an umbilical hernia, no big deal. But if you've got the stomach in the umbilical cord, that's a little harder to survive, right? But they put these little silo things over, and they repair. They like put them. It's a weird thing. Anyway, but they can both be born vaginally. Although more and more they're doing these births by C-section, although there's no reason to. They just have to repair them after birth. The big problem with this is whatever caused that defect often caused other defects. And so congenital anomalies rarely occur as just one. They occur as 2 or 3 or 6 or 10 at the same time. Okay? But we keep the contents sterile by wrapping them in nice sterile moist gauze and position them above the defect. Make sure the baby has an NG tube, and we replace the fluids IV through TPN instead of feeding them, of course, because we want to maintain. They're doing bowel surgery. Why are there duplicates? Okay, that's weird. So, care of the high-risk newborn. So now, we're going back to, so we talked about a few diseases or a few conditions specifically. Now, general overarching care things for high-risk newborns, okay? Understanding that they're, especially when we're talking about preterm babies, that they're neurologically immature and they can't handle a lot of interruptions. So we want to pay very close attention to their vital signs. We usually have them on continuous monitoring. You can take normal blood pressures of your premature babies, and they read just as well from an external blood pressure as they do with invasive monitoring. So they're fine. The NICU practices this thing called cluster care, where they do everything at the same time. All right? You don't want to constantly interrupt the baby. You want to give them as many hours of uninterrupted time each day as possible. So you cluster everything together. You take their vitals, give them a bath, change their diaper, draw blood, all at the same time, and then leave them alone for long periods of time. And then you do it again. Take their vitals, do their, draw their blood, change their diaper, feed them, all at the same time, and then give them long periods of uninterrupted rest again. okay? Nutritional care on premature babies is incredibly important because they need to be able to grow, and they can't grow without the protein. So you need to achieve that positive nitrogen balance that we talked about when we were talking about proteins back in the nutrition course. You can do that either IV feedings or parenteral feedings, depending on, we want to go as close to normal as fast as possible. So babies who are born after 32 weeks usually have the ability to coordinate suck, swallow, and breathe at the same time. And so our late preterm babies and our 33, 34 weekers, they can usually go to the breast, or at the very least can get bottle-fed breast milk. But our babies who are less than 32 weeks, they struggle with sucking, swallowing, and breathing, and they tend to aspirate or have an uncontrolled suckle, and they can't effectively get milk out of the breast. And so for those babies, mom will pump and then feed through an OG tube or something like that as often as possible. But if you've got babies, especially extremely premature babies, their gut isn't mature enough even for breast milk yet. And so they often are on TPN for a long period of time. And so we use total parenteral nutrition. We start off with our regular TPN, and then we can add lipids, just like we do on sick people. Okay? They very rarely do you have exclusively breastfed premature babies from the breast. We're often supplementing them with express breast milk as well. So we're doing a mix of breast and bottle. It depends on how good your NICU is at maintaining it. But even healthy places with wonderful breastfeeding rates still find that they supplement newborns an awful lot in the first few weeks when they're premature. It's very important for NICU babies to practice non-nutritive sucking. It's not only a soothing technique, but just like with the babies in SIDS, it keeps them alert and helps them prevent the apnea and bradycardia periods. So we practice a lot of non-nutritive sucking in our premature infants. Strict monitoring of I&O, and how do you monitor urinary output in a newborn, or in a premature newborn? You weigh the diapers, exactly. And when you weigh the diapers, what are you weighing? How does it work? You take a diaper, you put it on the scale, and it goes up. Okay, so you subtract the dry weight, right? So I usually start with a dry diaper and zero it, then take the dry diaper off and put the full diaper on and weigh it, okay? And it goes up, I don't know, 45 grams. How many cc's of urine out is that?
45 grams.
45 grams. So how many cc's of urine output is that? 45. It's 1 to 1. 1 gram is 1 cc.
Is it?
Thank you for
1
that.
gram, 1 cc.
I thought milliliters.
Is it 1 milligram?
Yeah.
Sorry, 1 milligram is
Milliliter.
1. Sorry.
Okay, yeah,
No,
don't make us-
1 milliliter is 1 cc, but I mean, when you convert weight to volume, it's a 1 to 1, whatever your grams are. So 3,000 grams is 3,000 cc's.
Oh.
That's a lot.
Yeah, well, no one's gonna pee that much, right? At least not very many premature babies are. Now you guys got me double checking, let me go back.
At the
'Cause-
PICU,
It does say
and,
the answer form.
at Cape Fear, they have like the scale or whatever, cause all of them are on strict INOs.
Right,
And so they have the scale, and then above the scale, they have the list of like what each size diaper weighs
Uh-huh.
regularly, so all you have to do is subtract it.
right.
You don't have to worry about zeroing out the scale and stuff.
Well, that makes sense. But like, I don't know how much a chuck weighs off the top of my head. So when I weigh them dry and then I weigh them full.
But I know like they have a set standard where they look at the size of the diaper first, and then they have a set weight that they
Right.
subtract it from. So you don't have to individualize every time. Individualize.
But I know it's 1 to 1, I just don't know if it's 1 gram. Yeah, it is 1 gram.
I said you were right over there.
Okay. But yeah, so it's 1 to 1. So, and then skincare. Skincare is a big deal in our premature newborns because they have bad skin, right? And they're spending an awful lot of time in bed. And when they kick, they shear their heels. And so they get a lot of skin breakdown on their bony prominences, on their heels, on their knees, on their tailbones, on their shoulders, just like old people. And so skincare is a very, very big deal. And then developmental care. We want to make sure we minimize noise and light handling and positioning. We want to leave them alone. as much as humanly possible. And so we put them in ththese isolettes and we cover these isolettes and they get, and you just leave them there for long periods of time. And then we can, I saw a new isolette recently, it's called, not called a kangaroo, but something like a kangaroo, that they had at the NICU that enabled them, they were humidified and perfect. It was really neat stuff. It was as close to the womb as we've ever gotten. But they will often have little armholes to put their arms through and do their care and then come back out again. So there's no, you don't open the thing ever. You just go through the armholes and fix them and then come back out. It's pretty neat stuff.
That's what it sounds like, a Skinner box.
What's that?
Sounds like a Skinner box.
A Skinner box?
Skinner?
I don't know what a Skinner box is.
No, never mind.
So when you go to the NICU, it's important to understand that you need to form a partnership with the parents, okay? Remember, these are the parents of the child. And anytime in pediatrics, you've got parents who are gonna want to take care of their child. That's what parents do. And so in the NICU, the nurse and the doctor are responsible for the care, but the parents are gonna wanna be there as well. So you wanna know what their expectations for parenting are and encourage them to do as much of the care as they can. They're not gonna be drawing blood and that kind of stuff on them, but they can certainly change their diapers. You can teach them how to feed the babies, that kind of stuff. I mean, you guys, there's nothing magical about you guys that makes you nurses and means you're capable of doing what a mom can't do, right? So most of the things, routine baby care, like feeding and changing diapers and that kind of stuff, of course the parents can do. They just need to learn how to do it. Creating a partnership with them, encouraging, touching, and loving on the babies, and spending as much time in skin to skin as possible with that kangaroo care. We found that kangaroo care is a remarkably protective thing for newborns. And so we want to keep them skin to skin and kangaroo care as much as possible. And from the moment they're born, we're talking about when are they going to be able to leave? What are our discharge criteria? How are we doing in preparing for that? Understanding is the more premature the baby, the more the premature the baby is, the more likely they are to have prolonged chronic problems. Problems with breathing, maybe needing to go home on a respiratory monitor, or maybe even going home on oxygen, or going home with an ostomy bag, or going home, with feeding tubes or a peg tube. These babies in the NICU, most of them, about half of them are going to make it out unharmed, but the other half are going to go home with special devices and needing special care. Okay? And then your book talks a lot about HIPAA and understanding. If you're in the mother-baby floor, okay, you've got one patient in one room. If you're in the NICU, you've got 40 patients in that room, okay? And so the parents are always like, what's wrong with that kid? What's wrong with that kid? And you have to make sure that they know it's none of your business what's wrong with that kid, right? And so you just explain, they can take pictures of their own baby, they can do all that stuff, but they can't involve anyone else. So other babies in the NICU, other parents in the NICU get privacy just like their baby gets privacy. And so that's a big problem in NICUs, is they talk and they share and they become little spies and try to figure out what's wrong with everybody. And
Well,
it's
the
so,
PVD, you don't know how many times, what's wrong with that kid? that
yeah,
you walked in?
exactly,
I
yeah.
don't know, that's what I was
Right, exactly. Like I was up on the PICU a couple weeks ago, and there was a little girl there with obviously some kind of head trauma, and she was in a medically induced coma. And I wanted to ask what was wrong with her, right? It's just natural. You want to ask what's wrong with them. I knew not to ask, but I was dying to know. So the one question I did ask was her urine was black. And I was like, why is there black urine? And they said, oh, that's propofol. Oh, okay. So that wasn't anything about the girl. That was just, I was curious why there was black urine. But understand that HIPAA is important. I was thinking about something else. It was really important about the NICU. Just a second ago and I lost it. Yeah, it'll come back or it was a lie. I don't know. So, that's right. It's either a lie or not important, right? So 3 different types of NICUs. There's a level 1, level 2, level 3 nursery. Level 1 nursery is a normal nursery for normal babies. Nothing's wrong with them. They're the ones that shouldn't exist anymore. Okay? Because babies aren't animals in the zoo on display for old people. Babies are supposed to be with their mother. I hate that display nursery. Cape Fear has these big old display nurseries. And I'm like, if I ran that place, those curtains would be down 24 hours a day, 7 days a week.
Oh, no, they get angry when the curtains are down.
I know, only because they expect to see babies on display. And I always say it's none of your business what's wrong with that baby or whose baby that is.
Oh,
Okay?
I know, but I'm just
Yeah.
saying, I don't know how many times
yeah.
I like walked this,
That's what it was. It was about HIPAA. In the NICU, you will notice if you spend any, that during report, they kick all the parents out of the NICU, okay? So there's no visiting in the NICU from like 6:45 to 7:15 while they're changing shifts, so they can talk about all the babies. And so parents need to know that there are times when they can't be there because it would interfere with the privacy of other patients. That's what it was. And that goes back to that whole visiting nursery thing. We know that hospitals that have a nursery on display are more likely to have a baby stolen by crazy white women, okay? Because there's always them stealing babies. Because the baby's on display, they shop, they pick that baby, and they're gonna figure out how to steal that baby. So yeah, so a lot of hospitals, most hospitals don't have display nurseries anymore. And whenever people ask me why there's no display nursery at NICU, at WOMAC, I say because they're not animals in the zoo. They're not here for you to look at. If your baby is here, then you know where your baby is. He's in the room with your mother. Okay, done. Okay, you don't have any business looking at someone else's baby. That's not your place. So, but that's the level 1 nursery, sorry. Then there's a level 2 nursery. Then there's a level 2 nursery. Level 2 nurseries take care of moderately sick babies. They can provide IV care and they can provide oxygen care, but they don't usually provide care of babies on ventilators and that kind of stuff. And there's level 3 nurseries. Level 3 nurseries are the extremely advanced nurseries, the ones that have the ventilators and TPN and incubators and ECMO machines and that kind of stuff. Now that's an incredibly simple way of looking at it. There are level 2A, level 2B, level 2C, level 3, level 3B. Cape Fear is a level 3 NICU, but I don't know if they have ECMO capability. There's a special kind of NICU that has ECMO capability. And so they're both level 3, but one is more than a level 3. So you hear them called level 2 plus or level 3 plus. But in general, just know that a level 1 nursery is for well newborns. Level 2 nursery is IV monitoring, or basic oxygen and IV. Level 3 is for ventilated babies, babies who are much more sick. Okay. Now, when we discharge these moms from the NICU, and you notice I say discharging the parent, okay, bless you, because the baby is the patient, but you're really discharging the parent. They need to know all these things. We teach every NICU grad, we teach their parents CPR, because these babies are very high risk for SIDS, they're very high risk for apnea and bradycardia, and so they get CPR training before they leave. We teach them about environmental safety and sleep safety. Car seat training. Has anyone seen a car seat challenge yet?
Mm-hmm.
What is a car seat challenge?
Is it when they put them in the car seat and check their vital signs to see if there's any kind of distress with them being in the car seat to make sure that they're safe?
Did you see how long they stay in there?
No, I didn't.
30 minutes. Yeah, they have to be able to spend 30 minutes in a car seat without having any alterations in their vitals and stuff. So, but they do these car seat challenges to make sure the babies are safe to go home. Okay? Because obviously if they can't sit in a car seat, and you can't send them home, right? We teach moms and dads how to work the monitors if we're going to send them home on monitors, recognizing signs of illness, how to give medications, how to use the oxygen machine, what skin care to provide, how to breastfeed, or what formula they might be needing to use, and what vitamins. So we teach them all the nursing care that we've been doing for the last few months, and we make sure mom and dad know how to do all that stuff when they take the baby home. Because these premature babies are sick for a long time. They're not normal when they leave the hospital. They continue to be the same premature baby and have similar problems. They're just better, so they don't need to be inpatient anymore. A good friend of mine, Kimberly Rosenbaum, she is a labor and delivery nurse herself, had a baby born at like 26 weeks, and the baby lived for 13 months and then recently died last month. Continued for the last 13 months having all kinds of health problems, in and out of the hospital, pneumonias, that kind of stuff, and eventually succumbed. They're not all, it's not like everything else where you discharge your baby at 40 weeks, you're done, your gallbladder's out, you're recovered, go home, and it doesn't work that way. They've got a lot of these same problems. And so it's very common for them to continue to have problems after they're born. And I always want to talk about perspective here. Perspective is a magical thing, very magical thing. Parents and healthcare providers have very different views on what is normal and not normal, what you want or what you don't want. And it's important to understand that no matter what happens, these babies are not your babies, okay? They're not yours. You don't get to say, I want this or don't want this. It's not your business, okay? Our job is to read the perspective of the parents and to follow from their perspective. I have never yet seen a baby born with a birth defect and have a mom say that's an ugly baby. Never once. Okay? I've never seen a baby born prematurely and have a mom who say, I don't want him to live. Never. Doesn't matter 24, 25, 26 weeks. Doesn't matter, there's going to be a long, hard road ahead. They are always immediately enamored of their baby. They absolutely love them, every moment of it. And they spend an awful lot of time acting with their 26-weeker the same way they would have acted with their 40-weeker. Okay? Doesn't matter birth defects, doesn't matter anencephaly, doesn't matter spina bifida, doesn't matter omphalocele. They have the exact same response as normal mothers and normal fathers. As healthcare providers, we say things like, gosh, I wouldn't want a 24-weeker. 24-weeker's got like a 50-50 shot at death. It might just be better to not resuscitate him at all. We can say that as healthcare providers, but not to mom and dad, right?
Yeah.
Because to mom and dad, that's their baby, okay? And I think, was it? That don't help. Alyssa, you were talking about a niece who was born with holoprosencephaly, right? Okay, and so, you want to tell the story? No? Then I'll tell it for you. No. So, a very good friend of mine, this is not Alyssa's niece, but my friend John Hall, he's a helicopter pilot for the Army. He had a daughter born with holoprosencephaly as well. Her name is Leila, and she is now 6 years old, 7 years old, and she's healthy and strong, and I wish I had put a picture of. She looks like a baby with a brain disorder, okay? She's got, it's obvious that she's got a very big problem. And, from a medical perspective, when we look at this baby does not interact with the outside world, okay? This baby is severely brain damaged, has very little brain function, just enough to breathe and eat, and that's about it. But she's on a feeding tube, she's on oxygen, she's in and out of the hospital with pneumonia all the time. And my friend Don says that Leila is the most beautiful baby he's ever seen in his life. When I look at that baby, that's not what I see. What I see is a very badly brain damaged child who will never get bigger than she is right now, who, if she survives much longer, is going to be an 18-year-old having to change her diapers all the time. And so when I look at her, I think of all the nursing care that's going to go into taking care of this child. And I think about all the trauma that she caused this family over their life, in and out of the hospital and fear and that kind of thing. Very much like, who's that guy, Rick Santorum. He's got a daughter with some genetic defect. I can't remember. He wrote a book about her. What's that?
Isn't that a wrestler?
What's that?
Is he a wrestler? Who is he?
No, Rick Santorum. He's a senator.
Oh.
Ran for president 4 years ago. But he had to pull out because his daughter got sick. Her name is something like an angel, but I can't remember what it is. Anyway, but he had to pull out from the campaign because his daughter her health became too bad and he had to leave the campaign trail to deal with his sick daughter. And so, but when you ask parents about these children, it's all sunshine and roses. It's all beautiful and loving. And my friend swears that his daughter smiles at him and responds to different things. And she might. But it's so subtle that we can't see it. Okay? And he's desperately in love with this little girl. Even though for us, we're like, wouldn't mind, I don't know if I want that. And that's because our perspective is different. I don't look at her as a daughter. I look at her as a medical problem, as somebody who has a condition that needs to be addressed. Yes?
I had a patient in the NICU this past week, and kind of along the same lines, like she was obviously, she had a lot of care. Am I allowed to say what she had?
You can.
Okay, she had cerebral palsy.
Okay.
And really, severe mental defects and stuff like that. And I was, almost in awe of her mom because she was so, like you said, she was by her bedside all day. And if she wasn't there, her daughter was there. And they would constantly ask how she's doing, updates. And it wasn't those nitpicky families.
Yeah.
They were just genuinely curious about how, their family member was doing. And I just kept thinking, because she was older, she was 18, and so they had done this for 18 years, and I was like, that is, it just shows, how much that, you're right, they don't see the defects, the love for their child is so great that they, it doesn't matter to them that they are severely handicapped, but I was just thinking all the time and all the energy spent on caring for this child, like she has a younger one than her, and so I was like, wow, like kudos to her for having another child after having to care for her too. You know, that was
Right.
just amazing to me.
Yeah, and the interesting thing, it's the new normal, right? It's the only normal they have. This is how you parent. They don't think about it as a difficult child or not a difficult child. This is just how you parent. This is what you get, you know? And my favorite example of perspective, of a personal thing, is my daughter, you know, she's a leukemia survivor, right? So, and when she was just before her 6th birthday, she was diagnosed with leukemia. And so they put the port in her chest, and they were giving her all these great chemotherapy drugs all the time. And so for the first month, she was in the hospital, you know, for an entire month, okay, getting her leukemia into remission. And then every 3 weeks, she would go in for a dose of intrathecal methotrexate in the operating room and a 24-hour run of methotrexate IV through the port in her chest. And so, you know, she's got the scraggly hair of a girl who's on chemotherapy, and she's, you know, kind of pale and deep-set eyes, and she looked very sick, right? And one day we were in the hospital, and they had a singer, because it was Hasbro Children's Hospital in Rhode Island. So you can imagine a hospital that was run by a toy company. Okay, this was a wonderful hospital to be in for little kids. They would get in the cars and drive themselves to the operating room in a little electrical car, and drive to the operating room. It was so much fun. And she got to push her own propofol and knock herself out. They'd hook up the propofol, and she'd go, "Good night, Daddy," and go out, and then, you know, they'd do her thing. And so it was really, you know, it was a wonderful Pete's hospital. But they brought in a singer one day to come and sing to the kids. And on this day, I don't know why, but they brought all the kids together into this one kind of auditorium, kind of like this size room. And so my daughter and I are sitting there side by side, and they were running the methotrexate. And so methotrexate is this bright orange liquid, and it's in a big old biohazard bag where they're covered with brown, and you can only see like danger, danger, you know, radiation danger, right, on this bag. And it's bright orange liquid running down into her chest. And so she's sitting there watching the singer, and she started looking around and saw a lot of other sick kids. And she's like, "Psst, Dad, what's wrong with that kid?" And I said, "Oh, his throat looks kind of sore. It looks like he had a tonsillectomy." "Oh, okay." And then look at "What's wrong with that kid?" "Oh, I think he had a tonsillectomy too." And after like 3 or 4 kids where I told her they had tonsillectomies, she said, "Boy, Dad, I'm glad I have cancer and not tonsillectomy, because those kids look really sick." And that's perspective, right?
Yeah.
She had no concept that she was sick. She felt okay, and she just had cancer, no big deal. And these guys are, "Oh, tonsillectomy. Oh my God, whatever tonsillectomy is, that's terrifying," okay? And when she was finished with her treatment, the first time she got a sore throat, and I was looking in her mouth, I said, "Oh, your tonsils are swollen." "I don't need tonsillectomy, do I?" "No, I don't think you need tonsillectomy." "Oh, thank you. Oh, good. I'm so happy." And she wanted cancer, but she wanted cancer again because she didn't like being normal. She didn't like people treating her like she didn't have cancer. But she didn't want tonsillectomy. Tonsillectomy is terribly scary stuff. And when she was 14 or 15, she actually had to have a tonsillectomy. She was terrified of it. She was so scared. She had had 13, 14 surgeries. She has a permanent scar running up her back, looks like tiger stripes from all the intrathecals that she had. She's got problems from her chemotherapy. But oh my gosh, a tonsillectomy! Oh, it freaked her out having to have her tonsils taken out. And we waited as long as we could. And that's a really interesting example of perspective, isn't it? She had a life-threatening illness. She could have died. And it didn't bother her at all, okay? And what was interesting is she would get together with the other kids, cancer kids in the clinic, and they would compare their cancer stories. It was pretty neat. Like, "Well, I have chemotherapy for 2.5 years. It kind of sucked, but they took your leg off, you know? Well, yeah, but they took my leg off, but I only had chemo for like 3 weeks. I'm fine. Look at me on my stump. I'm fine. You know, I can walk with my what are those things called, a prosthetic, you know? Or, you know, well, you had a Wilms tumor. They took your kidneys out." "Well, yeah, but it was only one kidney. I still got another one," you know. And it was always like, my problem is no big deal, but your problem is worse, no matter what the problem was. And so the same thing goes for these NICU babies. The same thing goes for these babies with anencephaly. The same thing goes with all these conditions that are not compatible with human life. It's not our perspective that matters, and we need to keep our feelings quiet. And we need to ask the parents what they think, and we need to follow their lead, because they're going to tell us what they need. Okay? And so it's very important. Never put yourself into the situation. It's invalid. Okay? Your own experiences are worthless when it comes to that. So I had hoped to get to child development and I didn't. I apologize. We'll have to do child development next week. So just for clarification, we're still gonna do, the paper is going to be due midnight on Friday night, either by email or turn it in. We're going to do a test on the 17th, not the 10th, right? And the test on the 17th will cover whatever we finish talking about next week. So I can foresee child development is realistic. We might get to the care of the hospitalized child, but let's not push it. Okay, we'll do whatever we can. Okay, and if you're not in clinical on Wednesday and Thursday, you're in the Sims lab Wednesday, right?
Or Thursday.
Or Thursday. Sounds good. Anything else?
Where are they for next week, Brian?
You're under week 11 in Blackboard.
Lab this week,
Oh,
Wednesday or
that's why I
Thursday, or
couldn't
next
find
week.
it. That was on week 10.
For the week after.
Alright. I'm not exactly sure we're in week 11, but I already
If you're
filled up week
not
10,
WOMAD.
so.
Oh, okay.
Take your pack only,
Okay?
Wednesday, Thursday, lab this week.
Right.
You are WOMAD, so I don't know what you're doing.
I'm on Monday.
Then that's next
And
week.
then,
Yeah.